Hi, everyone. My name is Dr. Moises Dominguez. I'm a headache specialist in New York. And today we will discuss the differences between preventive and acute treatments. So, acute treatments are basically treatments used to treat an individual migraine attack when it occurs. And it's also sometimes called a rescue or as needed or abortive treatment. While preventive treatments, which are also called like a prophylactic treatment, these treatments are taken regularly. So it could be daily or monthly or quarterly. And the point of this is to reduce the overall burden of the migraine. Each treatment has its own intention. So, acute treatment, the point of that is to provide some fast and reliable relief during a migraine episode. And preventive treatments, that focuses more on the long term control of the person. The point of that is to see, can we reduce the overall burden of the migraine over time with regular treatment? It should be strongly considered when the migraine attacks become meaningfully disruptive to a person's daily life. So that could mean, having frequent or disabling attacks. If the person finds themselves overusing a rescue treatment often, which we can talk about later, or if the acute treatments that they're using are not really working anymore, or they're causing too many side effects. And when you look at the person as a whole, maybe some acute treatments may not be safe or not a good option in them. So being on a preventive treatment makes a lot of sense. And also patient preference. Like sometimes patients may say, listen, I just want to be on a preventive treatment. I think one last thing to note is that there are people with less common migraine subtypes, like hemiplegic migraine, like that would be another indication, for example, to be on a preventive treatment. So the way that these acute treatments work, it's basically designed to interrupt the migraine process in real time. So migraine is a very complex neurological disorder that involves a lot of steps. And the point of the acute treatments is to sort of stop the steps in its track. So that way we can prevent it from becoming unbearable or difficult to manage. One way you can think about it, there are the simple non-opioid analgesics. So these are things you can get over the counter like acetaminophen, ibuprofen, naproxen. Then you have these combined non-opioid analgesics. So these are things like these combination treatments that have aspirin, caffeine, and acetaminophen that you can buy over the counter. Then you have the triptans. That's the sumatriptan, the rizatriptan. You have something called the ergots. That's the things that people can, something called like DHE. There are the G-PANTs, which are these newer migraine treatments that target a key pathway in migraine, and that's ubrogepant, rimegepant, zavegepant. Ditans, that's the lesmetidan that people can take as needed. And there's more. There's like medications that are used to treat nausea that could be effective in migraine as an acute treatment, like metoclopramide. So that's sort of like a basic overview of the options. So patients can use both. And so preventive therapies are taken regularly to reduce the burden of migraine. Acute treatments are used to treat individual attacks. So you can think of it as them forming a more complete care plan, one that aims to reduce both the frequency and the impact of migraine. So for example, let's say if someone is having 20 headache days a month, and then, they are placed on a preventive treatment. The goal is that the frequency of that headache reduces over time. Now, let's say if the person went from 20 headache days to 5, they still have to treat those 5 attacks. So that way they're not disabled by the migraine attack. So the acute treatments come in. So that's sort of an example of how they work together. But they create a comprehensive, complete treatment plan. That is a great question. And that is a big reason why understanding a person's full medical history is so important. So, for example, let's say if a person has a history of kidney stones, then certain medications like topiramate may not be the best fit in that scenario. Or if you have someone that has a history of high blood pressure and migraine, a medication like candesartan, which treats both, would be a smart choice. So, this is an example of how treatments have to be tailored to the whole person, what other conditions that they have, what current medications that they're using, their lifestyle, and also their preferences too. So it's really about finding what's safe and effective in that person's unique situation. The great thing about tracking is that it can tell the provider, is what I'm doing actually working? And also, what is the headache problem that's going on? Do I need to investigate further? Am I confident that this is the issue? So, when it comes to tracking, I'm in favor of keeping things simple when possible. So if someone was diagnosed with migraine and they want to see how they're doing over time, I would say the two biggest things for the person to track would be the total number of headache days per month. And it's important that you count all headaches. Some people may say, I have 4 headache days a month, but then you learn that they're qualifying those as a migraine, but they're having milder headaches almost every day. And that can definitely change how we would approach someone. So that would say part one, tracking the headaches. And the second thing would be tracking how often the person treats, because that can let us know, like, is our preventive plan actually working? Is there a risk of medication overuse headache in this situation? So that's also helpful. Now, there are some people who also track severity, the duration of the migraine attack, how disabling it is. And I think that's great if it feels manageable. But I think just starting small can give, like with just headache days in the treatment, can give us a clear picture of what's going on. So a couple situations. One is if someone is experiencing any intolerable side effect, that's a reason to adjust or switch therapy. So we don't have to wait for that. Um, if someone is on an oral treatment, then you want to give the person at least 8 weeks at a good dose before deciding if it works or if it doesn't work. And it's also worth noting that if someone has a partial response, so they're having some improvement, but not as much as that we would want, sometimes remaining on that treatment can give the person a cumulative benefit over time. That's part one. Other treatments like the self injections that a person can give themselves every month, you want to give it at least 3 months to determine if it's helpful or not. And with these quarterly injections or these quarterly treatments, like the ones that you do every 3 months, you want to give that treatment at least 6 months to know if it works. But I think the important thing to know is that it's not just about quick wins, it's really about giving the brain time to recalibrate and respond to treatment. Yeah, there are important population specific considerations when selecting certain migraine treatments. So for adolescents, you want to take into account developmental factors and how would they perform in school with certain treatments. In people who are older adults, you want to make sure that you're not giving too many medications, or you want to make sure that whatever treatment you're trying um, is helpful in the context of their medical history. And in people who are pregnant or postpartum, you know, there's like a shifting. You shift treatment to like more non-pharmacological options. So this is where things like acupuncture could be helpful, neuromodulation, things like that, but maybe prioritize in these cases. And then in people with chronic migraine, given how disabling that condition is, it also calls for a comprehensive multidisciplinary approach. So really with all of these groups, the key is individualized comprehensive care. And that's really integrating the person into what you know medically when managing these folks. Access and insurance challenges, they can be a significant barrier for many patients. So, for example, with the newer migraine preventive treatments, they may not be covered, or insurances may require step therapy where the person must try one specific type of treatment before gaining approval for the other. For example, prior authorizations can delay care. And if the person has to switch insurances or plans within their insurance for whatever reason, there is that risk of losing access to previously effective therapies. There's also these cost sharing barriers. So there could be high copays or deductibles, which also impacts access and ultimately, outcomes in the person. So to help patients, get or stay on an effective plan, the providers can document prior treatments and their outcomes in the person in well structured notes. So that can be really helpful when you're appealing things. Patients can prepare and write down all the treatments that were previously prescribed to them and what side effects they may have experienced, so that way they can give it to the provider and they can all document that. And also documenting like how has the migraine been disabling to them, so the provider should be asking those questions, but also having that ready in the visit will be great. So knowing like how much, how many days of class was missed or work, or did you have to go to the hospital? Did you, have to cancel plans? There's also like embedded pharmacy support or care coordination that can assist with prior authorizations and appeals. So they can really streamline that process and even empowering patients to understand their coverage and to understand how to navigate those denials. Those are really helpful. And even at the policy level, both the provider and the patients can advocate for legislation to expand access to these effective treatments. I would say one myth, that preventive treatments work immediately. And the reality is that it takes time. So sometimes a person may start a preventive treatment and then develop a migraine 2 or 3 days later, and they may think, oh, this is not helpful or not working, but it takes more time. So that's myth number one. I would say another myth is if I try one triptan, that means all the other triptans won't work. And that's not necessarily true. There are many people who don't respond to one triptan, but respond really well to another. So that's the other thing. Um, I would say, a third myth would be that you should wait until the pain gets terrible before treating. And it's not uncommon for people to wait and see, what will this turn? Will this be a milder headache that'll go away on its own? Will it be a really bad one? Hard to say, but treating early, especially at the first sign of an attack, really improves the chances of stopping it or reducing its impact. And I would say one last myth, if I had to give one, would be that, that acute treatments are addictive. But the reality is that most acute treatments, like the triptans, the gpans, non-steroidal treatments, they're not addictive. The concern is really more about medication overuse, which is really about how often a person treats. It's not about their dependency on it. One area that I'm very excited about is this targeted therapy against. It's a long name. It's PACAP 38, so it stands for pituitary adenylate cyclase activating polypeptide 38. So it's just a different molecule that seems to play an important role in migraine, and targeting that would provide a new class of treatment that's really exciting. Especially for people who don't respond to the treatments that we currently have. And I think the other thing is that this really reflects how our understanding of migraine is evolving. And that's huge because this then will open the door to more personalized and effective care. So this is exciting. So first, I think tip number one, know your migraine pattern. So understanding how often these headaches are occurring, how disabling they are, and how often you're treating is really helpful because this will let the person know, I should heavily consider a preventive treatment in this scenario. So I think knowing your pattern is huge. The second tip would be to treat early and not late. So you really want to treat the spark before it becomes a wildfire, in a way. So waiting until the pain is severe can make, um, treatments less effective, and it can be very disabling. So that's that. I would say the third tip would be individualized care because the reality is that there is no one size fits model. So treatment should reflect the person's medical history, their values, and how their migraine behaves. I would say the fourth tip would be watch for medication overuse and understand that it's not your fault. When a person is treating often, it's just a reflection that we just need better control of the person's migraine. That's all that means. And so it would be another reason to heavily consider a preventive therapy. It's not a reflection of personal failure. So that's that. And I would say the last tip would be advocate, for access to effective treatment. So if a treatment works for you, staying on it often means working closely with your provider, understanding your coverage, and getting support with appeals or changes in your plan. And so working closely with the provider and their office will be really helpful to stay on effective treatment. Managing pain, especially in pain conditions like migraine, which is a complex neurological disorder that is involving both pain and non-pain symptoms, it's really a journey of trial and error. Sometimes it's just part of the treatment. It's where we're pulling levers like, did this work? No. Did this cause side effects? Yes. And then we have to keep adjusting our treatment over time, all in an effort to find the treatment that serves the person best. So I just want, to let people know that it's really a journey of trial and error. But when it's found, it's great. Thanks to everyone for listening. I hope you all found this helpful and educational and empowering. And for more information, just look at the American Migraine Foundation website to learn more.